You mentioned treatment of what I call consequential factors of depression or whatever. Are you doing work on causal factors, such as trauma in childhood, which affects behaviour, emotional well-being until it's resolved?
Okay, so the question is just, are we focusing on treating causal factors of anxiety and depression rather than, I guess, current factors? Yes and no, mainly no. So no, the treatment that we do is very present focused, so we're focusing on what are the symptoms we can see now and how can we help people to resolve those issues now. But sometimes that also involves talking about things that might have happened in the past and helping people to perhaps think about how they can change their views on what happened, or how they can take meaning from that and move forward, or how they can stop that part of their life actually continuing to cause anxiety and depression. Yeah. So no, it's mainly very present focus. And in fact, there's some advantages in that, because in an older adult population, some people have experienced an awful lot of trauma, and you'd spend hours and hours and hours and hours just getting through all the events that have happened in their life. Okay, so there are some advantages in just trying to focus on what's going on for people here and now. Yeah. Yes?
To take part in the trial, can you just choose, make the choice yourself, or do you need a referral from a doctor? And what about people who are on medication for things like, bipolar and things like that?
Sure.
And, because I'm actually thinking of getting a couple of flyers and also giving them to a couple of friends that do have mental health.
Great. So just to summarise the questions so you can hear, just some questions about the trial and how to get involved and whether or not you need a referral and whether you can be on medication. So to answer that, no, you can self-refer, so no referral is needed from GPs. We're actually asking people just to identify themselves. People entering into a randomised controlled trial, which means that you don't get to choose which treatment. We allocate a treatment based on a random allocation, okay? But in terms of medication, what we do there is we ask people to keep their medications stable, because you can imagine that if you're also on antidepressant medication, it makes it hard for us to work out whether participating in our program was helpful or whether it was the medication that you're on. So we do have some rules around that, but all of that is actually described in the information sheet. Great. Yes?
In one of your slides, you showed the control group as being on the wait list, but I remember a long discussion between psychiatrists and RPA as to whether being on the wait list genuinely constituted not having treatment, because knowing that you were going to get help gave you hope, and that you would see far bigger differences in results if your wait list was not seen as a control group, but you had controls from genuinely not getting anything.
Wow, getting good scientific questions now. So the question was, I guess, about the genuineness of the waitlist as a control group, and acknowledging the fact that people on waitlist, knowing that they're going to get treatment in 12 weeks' time, can actually start to increase their mood and produce some benefits in itself. Look, you're right, and in fact, any type of control group often can provide some differences there. I guess the nice thing is that even though people may have improved on waitlist, is that giving them treatment in a group was actually much better than having people wait. That's right. But yes, there is actually a lot of benefit in just the diagnosis. Once people receive the diagnosis, sometimes they actually start to think differently about things, and that produces some effect. Yeah. Sorry.
I was just going to say that from your graph, those in the wait list got worse.
Yes, I think they did. Not statistically, it wasn't statistically significant. So that means that although it looks like it on the graph, they weren't. They were the same. Yeah. Yes.
Are you treating partners in conjunction with one another?
Sorry, I missed the question.
Are you treating partners in
partners.
conjunction with one another?
No, we're not. We're not. So the question was, are we treating partners? No, we're not. We're actually just treating individuals that present. But certainly in fun therapy group setting with all the partners in the room as well, I can imagine. But yeah, that's not something that we're doing.
Well, one partner may have a synergistic effect on the other partner.
Look, absolutely, and there's to be good reason to do that. It's not something that we're doing right now, but given that a lot of the distress that comes up in group is around marital conflict, that may be a step for the future.
Not marital conflict, just the personal.
Just the, yeah. I mean, people have often, in these age groups, have been together for long periods of time. So there's well ingrained patterns of communicating or dependency and all those types of issues. Yeah. I'll write that down. I'll write that from maybe another project grant for next time. Yes?
In that older group, what proportion were long-term sufferers of anxiety over many years, and how did they perform with the group equally in the depression, anxiety, going up?
Yeah, so the question then is, in the trial that I talked about, what portion of the people were long-term sufferers of anxiety and depression, and I guess was their treatment as equally effective for them as it was for those presenting with anxiety and depression for the first time? I actually don't know. I didn't look at that. I don't have that information. Yeah, sorry. I'll go here and then I promise I'll come to the left. Yes, thank you.
With the two randomised trials, like you said something about the first one being very prescriptive, and I'd like you to say a bit more about that. But have you at this stage compared the results between the two different types of treatment, and noticed any differences?
The question being, have I looked at the results, I guess, yet for this second randomised? No. Shortly, because I've got to present the results in Geneva in August. So very shortly, I'll be having a look. But we've actually just finished our first lot of 6-month follow-up. So the first about 30 or 40 people have actually been through the program. 6 months later, we're checking in with them again to see whether or not they've maintained any benefits that they gained. So that data is to be looked at shortly, but hasn't been done just as yet.
And with the first one, when you said it was very prescriptive, was that like CBT, cognitive behaviour therapy, or how did the first one work? Because I got what you said about the second one, but I didn't get
Yes,
all of it.
no, cognitive behaviour therapy. So meaning that we're teaching people skills in set ways, and they're just, particular skills are just taught in a very manualised way. Yes?
A lot of older people are immobile or isolated. Do you offer any online resources that they can access themselves?
So the question is, do we offer online resources because some people are unable to come to therapy? I don't, but luckily my colleague, Associate Professor Nick Titov, is actually, he heads up the E-Centre Clinic, which is a clinic dedicated to computerised treatments. And they actually have a computerised trial running at the moment for older adults with anxiety and depression.
We're just finishing the trial.
Oh, just finished.
We're about to begin another trial in about 6 weeks' time. I'm very happy to answer questions about that.
Yeah, so at this stage, the treatment I'm running is just face-to-face, but as I said, there are other colleagues who are running computerised treatments.
Is there a correlation between physical health and anxiety and depression in older adults?
So is there a correlation between physical health and anxiety and depression? Yes. Yes, not just in older adults, I think really just generally speaking. Yeah, and if you're physically feeling pretty miserable or you're in pain, then it impacts on your mental health, yes.
So you made a comment that the coping skills of older adults may in fact give less of an indication that they are suffering, but in fact it's that they're less able to cope when they're in physical pain. Would that be the logical?
Yes, it could be that because older adults are more likely to experience physical symptoms, so therefore it may be harder for them to cope. But again, the research suggests that older adults are better copers. They are just better able to put up with or find ways to distract themselves or somehow manage the stresses in their life.
It probably would indicate that down the line somewhere there has to be programs introduced into places like nursing homes for people to cope with.
Yeah, so I mean, ideally that's where this research would go. Okay, I guess one of the next steps will be starting to take some of these programs out of a university setting and out into the community and into nursing homes as well. In fact, there was a couple of groups around Australia, in New South Wales and Victoria, they've actually taken this Ageing Wisely program now and actually trying it in some residential aged care settings. So those trials are just starting, so I might have some results in a couple of years. Great. Any other questions? Sorry.
Coping, just taking that subject, it was spotted as a factor for the low incidence in one of your sides. I mean, that comes a bit from experience and coping across a whole range of things. I mean, when you look at the younger people today and the amount of intervention that is offered at almost every drop of a hat, whatever takes place, what are your thoughts about coping being able to, help as they age, because they become dependent more dependent on intervention?
Wow, that's an interesting question. So the question is, I guess, because young people might receive more help these days, does that mean they're becoming dependent on other people helping them with their problems? Oh, I don't know. It's an interesting question. I'd like to think that the interventions that we offer young people actually don't make them dependent. I mean, the types of evidence-based treatments that we use are actually about upskilling people and giving people better resources. And in fact, we find that when people receive good treatment early on, like in childhood, that actually might last them for a long time, actually. So I think Ron's got some research that suggests that anxiety disorders treated in children, 9, 15 years later, still other people. Yeah, so 8, 10 years down the track, they're actually still experiencing benefits. So they haven't had to go back in for repeated treatment. I guess the types of treatment we talk about are very much about building resources, so they're not so dependent on the therapist. And what we do know about coping skills in older adults, some of my students have looked at this, and we know that older adults are better at using problem-solving skills. So when a problem arises, they're more likely to jump in, work out how to fix it, come up with some solutions, while young people are more likely to pretend the problem doesn't exist. Any final questions? Yeah.
Yeah, the matter of spouses was raised. Suggestion for research, because I know your answer will be no, is anxiety in, say, adults in their 80s from unresolved issues from their kids 60 years ago that are driving fear and guilt, say if they're complicit in abuse of the child or something like that. Be an interesting research project.
I agree. But yes, obviously not something I'm looking at right now.
Yeah.
Great.